Most consumers have no idea how much medical care costs.
Exactly.
And we find that when consumers are actually armed with that information, you can actually change behavior. When consumers understand that and then they realize that they can get, the same level of care at half the price, they feel good about making that decision.
Hey, what's up, guys? Spencer Smith here, host of the Self-Funded with Spencer podcast, sponsored by Pareto Health, ClaimDoc, and PlanSite. Enjoy today's episode. All right, you guys, we'll kick off the podcast. I'm here with Josh Schreiner, right? Chief Product Officer of Health. I was going to say the wrong thing again, but HealthEZ. And then I'm here with Mike Mather, who's also the General Counsel of HealthEZ. So thanks for coming down, guys. I'm really excited about today's podcast. We'll get to know you. We'll get to know HealthEZ. But why don't you, Josh, if you want to do the honors, kind of establish what today's episode's going to be about.
Yeah, well, thanks, Spencer. We're super glad to be here and looking forward to a conversation. Mike and I have spent a lot of time in the last few years on No Surprises Act, transparency and coverage, a lot of the rules and regulations around how members need to be protected in the new landscape. And we've got a whole suite of product solutions at HealthEZ that help self-funded, level-funded employers comply with those rules and regulations. So looking forward to a good discussion.
Absolutely. So what do I do? We'll go introductions. We'll get your bio first, Josh. We'll come back to you to keep it balanced. But I want the audience to have a chance to get to know you guys personally a little bit first before we go into kind of the bulk of the conversation. So Mike, tell us a little bit of your bio, your backstory, sir, other than the super awesome dad socks.
Yeah, I'm glad I was able to wear them here today.
I hope they're in frame.
My daughter will love it if she gets a shot of them. But again, thanks, Spencer. Thanks for inviting us. So I'm the General Counsel here at HealthEZ. So that encompasses a lot of things. I spent a number of years before moving over here as a litigator, actually litigating a number of cases in the commercial space, whether it be contracts or shareholder disputes or really anything else that can come up in the course of a business. And about 2.5 years ago, I met our CFO about an opportunity to join HealthEZ. And it was incredibly interesting to me because what they were trying to do is they were really trying to up their game and bring some more resources in-house and take some of these issues that our consumers are facing from a compliance perspective and really turn it into a value add instead of just a check the box requirement.
Yeah.
So I joined HealthEZ a couple of years ago to really help with that and build out a team to help people like Josh and the rest of our sales team and our support team and our account management team really understand the landscape so that they can create the best products and provide the best services for our clients.
Well, yeah, and you mentioned check the box, and I want to at least comment on that. I feel like compliance has moved away from check the box to like the forefront of most people's mind, especially self-funded employers' minds. I've talked about it a number of times. It's becoming more sexy as a subject, I think, these days, out of whether necessity or desire to learn. But I think we are done with the days of, I'm just going to check that box and move on and let somebody else worry about it. These employers have to be thinking about it. Before we go into that, though, let's get your bio real quickly. I want to get to know you as well, and then we'll start digging in.
Yeah, absolutely. So I'm the Chief Product Officer at HealthEZ. I've been with the organization a little over 8 years. My original plan when I went to school at the University of Minnesota was to be an attorney like Mike.
Really?
And
Okay.
I got about 2 years in and decided that I didn't want to study that hard. And I ended up taking some courses on healthcare finance, healthcare administration, and realized that there's actually a lot of overlap between political science, just from the compliance perspective that we've already touched on. Plus, it's also a landscape that is the only constant is change.
Yeah.
And so when I was born, I did not think I would end up in this space, but after college, I ended up working on revenue cycle team for an independent kind of collection organization that worked for small provider groups throughout the country. And then a little over 8 years ago, landed at HealthEZ.
Were you always in the product space, though, when you came to HealthEZ, or how has your role morphed?
No, it's really morphed. My first real role with the organization is we actually manage and own our own PPO network. It's called America's PPO. It was founded in 1982, and it covers Minnesota, the Dakotas, and Wisconsin. Most of our membership is in the Twin Cities, Duluth, and Rochester, Minnesota. And so I actually, my first role was really actually working on contract negotiations with hospital and health system partners. It then, morphed into kind of more vendor and strategic management. I do a lot with pharmacy benefits. We have a whole suite of solutions for employers when it comes to that. And just in the last about 2.5 years, has really focused on product.
Okay. Well, there's two things I've gleaned. Both of you ended up accidentally in healthcare, right? Is that safe to say?
That's correct.
And then since Mike finished law school, he must be smarter. Is that also safe to say?
That's also accurate.
Okay.
Let's make sure that follows through and everyone hears that, right?
Well, so all right. So I want to kind of tell where do your two roles coalesce, right? Because we obviously have clearly distinct different roles. Your focus is product. Your focus is the legal compliance side of things. But obviously, you guys are friends and you work pretty closely together. So how do you morph your two roles? How do you guys help each other? I want to talk a little bit about the daily life and the interaction between you two. So open floor, whoever wants to respond to that first.
I could take it first.
Okay.
I mean, just from a product standpoint, anytime you're working in healthcare, there is an ever-changing compliance landscape. So when we're looking at new products, new vendor partners, new solutions, there is always some level of compliance related to it, whether it's just something as simple as a contract or the exchanging of data. I have to rely and work closely with Mike on contract language, on contract strategy. Everything we do from a product standpoint requires some level of compliance services.
Yeah.
No, I think that's right. So I view my role as kind of doing a couple of things. There's the HealthEZ aspect of it and just making sure we're licensed and ready to go and provide all of the services the way we want to provide them in all the places we want to provide them. But then there's the more interesting kind of side of it, which is really with our products, right? And I think the only thing people can really agree on in healthcare is that it's complex.
Yeah.
It is really complex. It's always changing. It depends where you are. The rules can be different. It's not always one system. We can have 51 different systems sometimes. And navigating all that complexity to help our clients develop a product that meets what they want to do in a way that won't get them in trouble. And I think that's really where Josh and I come together, where he will work with our clients and work with our partners to understand what does the market want? What are we trying to accomplish? What's our ultimate goal? And then I work with Josh to help make sure we can provide that in a way that kind of is staying within the lines.
Well, it almost sounds like the end is already set. What we need it to do is what we've established, which is what you do, Mike. And then Josh goes, all right, how do we reverse engineer the solution to that thing through a product? And when I hear product, I think product kind of in the technical world, the software world is product, right? A system, platform of some sort. But I think product for you encompasses the PPO network. It kind of encompasses vendor relations, everything. So that terminology product, is that really overarching and in terms of what it means for you in HealthEZ?
I think you're exactly right. It's everything. I mean, HealthEZ, for those of you that aren't as familiar, is known as a third-party administrator, but we really have a diverse ecosystem of product solutions that we've fully integrated to help partially self-funded and level-funded plans to control medical costs. And so for us, product is PBMs, it's PPO networks, it's cost containment, it's out-of-network solutions. It's even our new level-funded product called Easy Funding. So it encompasses everything that we can do and provide as a service to our employers. A big component of that, to your point on software, is as a third-party administrator in this space, you have to have a great member experience, which is one of our three main tenets as an organization. It's member experience, it's cost containment, and it's cost predictability.
Okay.
And so when we're talking to employers, we're trying to figure out which solutions under each of those three categories is best for that employer.
Okay. When you said something subtly in passing that I wanted to highlight, which is that partially self-funding. Most people don't know that they're partially self-funded. I actually, in my talk track, I established that. The reason I wanted to bring it up is, of course, partially self-funding is what the majority of employers actually are because they purchase stop-loss insurance. And it's a terminology and nomenclature that sort of is just that for ease of quickness of saying it, I dropped the partially. But I just picked up on that. I wanted to at least point out to let you know I was listening there. But so Mike, I want to talk to you a little bit about legal work in the healthcare space. Is it interesting? Is it, obviously it's necessary, but what is it about being in healthcare and working with self-funded employers from a legal lens that intrigues you? Pareto Health is the manager of the largest employee benefits group captive in the United States. And it's also now the main sponsor of the Self-Funded with Spencer podcast. I chose to partner with Pareto Health for three main reasons. Number one, their dedication to improving the world of health benefits. Number 2, their mission to reduce volatility and to make self-funding simple for mid-sized employers. And number 3, the strength and scale of their program. With over 2,300 member groups and more than $1 billion of stop-loss premium under management, Pareto Health is the most robust solution of its kind in the country, period. Stay tuned for more information because I'm sure I'll be featuring them on an episode of the podcast very soon. Visit Pareto Health at paretohealth.com or follow them on LinkedIn to stay up to date on the latest news and developments.
Well, I think, it's a combination of everything. There's obviously interesting components of it. Some of it is just kind of doing what we need to do, understanding what the rules are. But healthcare is one of those spaces where you have a lot of people weighing in on the same topic. Mm-hmm. You have the legislatures, you have Congress, you have the state legislatures weighing in, you have regulators weighing in and building upon those rules. You have customs and practices that come into play. Sometimes you have, the international markets will weigh in on things. And what you'll find when you start reading these things is they set up a general framework, but they very rarely ever tell you need to do this.
Okay.
Yes. So it leaves a lot of room to design and get creative and find the solution that works best for somebody. And then working with people like Josh and the rest of our team to say, we want to do this. Mm-hmm. And no one's really ever thought about it before. What are your thoughts? How can we make this work? And then understanding really what those guideposts are, where there is room to be creative, where there's room to be flexible, where there's room to find a solution that fits that particular problem within that general framework. We generally talk about law in the healthcare space as staying on the highway.
Okay.
And if you picture a freeway, there are defined rules, there's lanes, there's roads, you go this way, you go that way, and then there's the guardrails on the end. But it's wide, and that wide space in the middle is generally where we're operating, where the actual solid rules are way out on the edges. Yep. And everything in the middle is where you have that flexibility. So we're always trying to figure out where those edges are, where that flexibility is, and then using that knowledge to help a customer solve their problem.
Okay. Well, I want to come back to you in just a moment because I think CAA is top of mind, No Surprises Act is top of mind, gag clause attestations are top of mind as well. So I think we can spend some time there. But before we jump too far ahead, I want to kind of expound upon HealthEZ as sort of core services, right? You mentioned a third-party administrator. You mentioned you do some RBP. There's a PBM side to it. There's network side of it. So let's sort of like coalesce what you do from a product and service perspective so people can track along.
Absolutely. So we offer, like I mentioned, and you picked up on, we administer partially self-funded and level-funded medical plans. The three main tenets of our product and service are member experience. So we have a member experience team that's located at our offices in Bloomington, Minnesota, 7 a.m. to 7 p.m. We joke that if you call our call center, you'll actually get real live humans answering it.
Which is rare these days.
Which is very rare, in less than 30 seconds on average.
Okay.
We have a whole suite of integrated cost containment solutions. So we have 7 different categories that we focus on from a product standpoint. So it's things like smart coverage design. So we offer 3-tier network benefits. We offer narrow networks. We offer reference-based pricing. We have access management solutions. So where are we sourcing infusion services from? Are we getting them at a hospital? Are we getting them in a clinic setting? So we have a whole team that's dedicated to lowering employer costs while keeping members at the focus. And then the last and other important stool is our cost predictability. So we launched a level funding product earlier this summer. That is, we joke, a plan in a can. So it's great for employers that are fully insured and are just trying to get their toes wet into partial self-funding. And what it does is it gives them a predictable price, no health questionnaires, and access to their data. And what's also unique, and it is because we're third-party administrators, we return 100% of the surplus to employers.
Nice.
So we don't keep a penny of it.
Yeah.
And so those are kind of
That's a common constraint of level-funded products, especially the carrier-driven level-funded products. And that's one of the reasons I don't dissuade people from going down that path, but it's actually one of the primary reasons is, right, your surplus is being split with a carrier, and it's a credit to you next year at renewal, and it really is not designed for the employer themselves. So I'm glad you guys have that 100% of surplus.
And the other thing that I think is important about that product is, when we quote on whether it's fully insured or level funded, especially from BUCA carriers, the level of data that you have access to is not not helpful.
Yeah,
You know, it'll tell you who your top providers are, who your top drugs, you know, what the top drugs are that are being utilized by your plan, but it's not information that you can generally take any action upon. And so with our product, one of the things that I was passionate about making sure is that consultants, employers have access to their data. So that they can make decisions.
Well, I think that outside of chasing lower costs, I think that's the second biggest reason an employer should consider self-funding is access to data that you can actually use to make real informed decisions upon. So I'm glad. I mean, it sounds like obviously you guys as a business model are right in my wheelhouse of the things that I support. But like, talk to me real quick if you could summarize kind of core target market, ideal customer profile from an employer perspective. And I want to bring you in, Mike, but I want to at least finish this real quick and then let you take the reins here. So who do you work with?
So we work with employers generally between 50 and 5,000 lives. We work with school districts, county municipalities, private employers. Our geography, we're a nationwide TPA, so our employers, we have members in all 50 states, but our target segment is 50 to 5,000.
Okay, cool. And then at network access, you said there's quite a few, Cigna and Aetna across the country. And then we may go back to your kind of building a PPO and starting as a PPO. But Mike, why don't we do this, since you said there was probably 10 things ultimately that we could cover, but there was 3 or 4 that you felt were really relevant to today's conversation. We started over coffee talking about no surprises, but why don't you lead us down the path of the things that employers and their consultants should be thinking about from a compliance perspective right now?
So obviously we had the Affordable Care Act a number of years ago. That was a very big piece of federal legislation that really kind of had a big impact on the market. The most recent one that kind of did the same thing is this No Surprises Act. And I think it's important to kind of start with what do we really mean when we say No Surprises Act? Because we actually have a couple of different things that at least we kind of put under the umbrella of that phrase. And there's the actual law itself. There's a component of the CCA, the Consolidated Appropriations Act, that was this No Surprises Act. And then as we had touched on before, then there's rules and regulations put out by the departments that build upon that, and that's the transparency and coverage final rules. And we tend mostly for administrative efficiencies and kind of just shorthand call it all the No Surprises Act.
Yep.
But there's a number of things in there. I think there's probably 10 big things and maybe a couple more smaller components of those laws, and they kind of fall into 3 buckets, right? So you have your enhanced rights for patients, and that's going to be your protection against surprise medical bills. It's going to be your continuity of care protections. You have a bunch of transparency rules that we can talk about. That would be, your cost comparison tool, your provider directories. There's enhanced compensation disclosures. And then you have just some reporting, which is probably not all that interesting, but it's one of those kind of check the box got to do. And there's 2 big reports that come out of that. There's the pharmacy drug spend reporting, an annual report, and then there's these machine readable files, which I think a lot of people have talked about and heard about, that are absolutely massive amounts of good data. And I think right now everyone's trying to figure out, what do I do with this information, right? So within there's a number of things that I think are interesting, but I'm just the lawyer, right? It's all interesting to me.
Well, let me ask you just a broad sweeping question. On balance, do you think directionally these regulations are moving the industry in the right direction?
I think they are, right? So what they're doing is they're trying to do 2 big goals. And I think it's always important to kind of start big and narrow in, is what are we trying to do with these laws? And I think there's 2 big holes that they were trying to fill. Okay. The first is these protections against unexpected, large, out-of-network medical bills. Yep. So that's your No Surprises Act kind of proper, right? To kind of close that hole and protect the consumer from big unexpected bills.
So as an example might be an air ambulance trip, right, that they didn't select to go on, it was out of necessity, happened to be out of network or whatever the case may be, hundreds of thousands of dollars. I, as a member, right, might be stuck with the balance of that bill, or find out it's out of network and therefore my coverage differs as a result of that. So what does the No Surprises Act do to protect the member or the patient in that situation?
Yeah, I think you hit it right on the head. What it does is it takes a couple of core situations where you, as the consumer of healthcare products, aren't in a position to make informed choices.
Yes.
So there's three categories, right? There's your emergency services, there's your ancillary out-of-network providers that are providing services at in-network facilities, and then they're your air ambulance. But all three of those fall into the same idea where when you need these services, you're generally not in a position to make choices.
Yes.
If you're in an emergency situation, nobody wants you to stop and go on the internet and make sure you're finding that in-network provider. That's not what you're going to do. You're going to go to the closest place to get the services you need, and that's what you should do.
Sure.
You should be incentivized to do that. So what this law does is protects you in those situations from getting that large bill, a month or 2 months down the road, where it says it doesn't matter in an emergency context. It doesn't matter if it's in network or out of network. We're actually going to collapse that concept entirely.
Okay.
Everyone's in network from your perspective, from the consumer, from the patient perspective.
Okay.
And it sets up a relatively complicated framework of how you get down to the nitty gritty of what the dollar amount is. But at its core, what it says is you are going to pay as if it was an in-network provider. So you're going to pay your in-network cost sharing. It's going to be credited as an in-network provider. And then the amount, if you have a co-insurance, for example,
Sure.
the amount that co-insurance is applied against is going to try and replicate that in-network amount. Then it pushes off the actual negotiation of the ultimate price onto the plans and the providers to figure that out. But I think what it does is it really incentivizes and pushes the patient out of that conflict and protects them from that fight that's inevitably going to happen, gets their portion of it resolved so they can go on with the rest of their lives, and then pushes the rest of the conversation to really where it should be. You have your provider and your plan.
And that's a dispute resolution step, right? So where does HealthEZ come in to assist with that resolution of that final payment amount so that people can move on? How do you guys help?
Yeah, so we provide end-to-end solutions on this, right? So on the front end, when it comes to identifying these claims and making sure the benefits are applied appropriately is the first step. And then when disputes arise, you had mentioned this independent dispute resolution or IDR process. Yeah. And what that is it's really a unique and specific claims appeal. So instead of doing your normal claim appeal where you submit an appeal, you submit information, it goes to the plan, and then they run it through their process, they said for these claims, we're actually going to set up a system that mimics arbitration.
Okay.
And it will have this ability to, you submit your claims, the payer and the provider will essentially stake out their position. They'll say, I think it should be this amount. I think it should be, the payer will say it's this amount. The provider will say this amount. And then it goes to these neutrals who have a set of guidelines that they apply and then ultimately pick either the plan's number or the provider's number.
Yeah, this
and
is
that
the funny thing
the
you told me over
solution, right?
coffee, and I had to make sure I was correct in my understanding. There's no compromise, there's no negotiation, it's an either or. It's a binary decision, one person's right, one person's wrong, and it could be a huge disparity between those two things, right? And they just pick. Am I correct in understanding?
That's 100% right.
Okay.
And some of that is built into the incentive structure. We always talk about incentive structures. And here, what it is they're trying to incentivize is to avoid the process altogether.
Okay.
What it really wants you to do is take the framework of the No Surprises Act and how you think about how the cost should be determined, and then you two figure it out. So before you even get access to this arbitration process, you're supposed to go through a 30-day good faith negotiation. And that's where the horse trading should come into play, where you take, plan thinks it's $100, the provider thinks it's $1,000. That's where you should be finding the solution, that happy middle ground.
Yeah.
Let's just split the baby, we'll call it 500. If that fails, then you can go to this arbitration process. But the risk of going there is it is now that binary choice.
Yeah.
So the plan will submit, we think it should be $100, and here's all the supporting information that supports it's a $100 charge. The provider will do the same thing to support why they think it's a $1,000 charge. And then the IDR entity is supposed to take the framework set up by the law, what can you consider, what can you not consider, and then pick one. So there's a lot of risk associated with it.
And so before I want to go to care coordination next, and I talk about that from a product lens. But I want to ask you though, you telling me the pipeline of this has swelled pretty significantly, where there's a huge backlog of these IDRs to yet to be reconciled, and so now there's become this waiting period. So tell me a little bit about how the scale of the interest in doing this, today, and then how big is that backlog?
Yeah, it's probably one of the two biggest challenges that process is facing today, which is just the volume of disputes that have been submitted. I don't know the exact estimates that CMS kind of built their model off of, but there was a report that came out that after the first year, I think they had 335,000 disputes get submitted into the process.
Okay.
So those are ones that had a dispute had been identified, they had worked through the 30 30-day negotiation period, were unable to reach a resolution
Yeah.
and filed the claim. So the process is designed under the regulation to be like a 60-day end-to-end process. From the initial submission, we need someone to rule on this dispute, to the ultimate payment of the resolved claim is supposed to go 60 days. The reality is it is taking months. That same report said after the first year, of those 335,000 claims that got filed, only about 42,000 of them actually made it through the whole process.
So the other are just waiting in limbo or waiting to be reviewed?
They're just waiting in the line. So, kind of backing up a little bit, the way it's designed to work is on Monday, you submit the request to have a neutral resolve your dispute. On Wednesday, they pick the neutral, and by that next week, Friday, 10 days later, you're submitting all your information. 2 weeks later, you're getting a decision. 30 days later, you're paying. That's how it's designed to work. It's the super highway of appeals. How it's working in practice is that Monday and Wednesday are happening. We have a dispute. We're picking our neutral. And then on Thursday, the neutral's saying, we are overloaded with work.
Yeah.
Don't give us your information yet. We'll tell you when we're
So
ready.
it's a human capital constraint right now. There's just not enough people that can review.
There's a couple of things. I think there's the number of entities who are certified to perform this service. There's their ability to do it in terms of just their human resources. I think the system's overwhelmed. I don't think they anticipated this many disputes. And then the last piece is there is this ever-changing landscape of what they're actually supposed to do. That's the second challenge that this process is facing, is that it has been overwhelmed with litigation.
Yeah.
On specifically on what you consider when you're calculating this. It's called the qualified payment amount, or the QPA. And what can you consider when figuring out that number? What can you not consider? And actually, Texas has been the hotbed of this
Really?
litigation.
Yeah. Is it really? Okay.
There's probably, I think, a series of 4 lawsuits now constantly challenging 2 things. It's that consideration of factors of what can be considered when you analyze what the ultimate amount should be, and then the fees associated with the process.
Okay.
It started relatively nominal at about $50. $50 a dispute, kind of just a service fee into CMS to keep the process running. That then got inflated to $350, potentially as just an incentive structure to maybe bring these disputes down. And there's been litigation over whether that was proper, whether it should be that high, and that continues to evolve.
Golly.
So every couple of months, you'll have a new decision come out that changes the game.
Yeah.
So then you put a pause in the process so you can reevaluate the rules. How do we have to adjust our
What
process?
is that? The road to hell is paved with good intentions. The intention of the law may have been good, but here we are, right? And I do want I want to establish real quick before we move into care coordination. And I've never heard of that before, so I'd love, Josh, if you weigh in, and if you need to phone a lawyer friend, you're welcome to do that. But we are talking. This is November 2nd of 2023. The reason I bring that up is this may not go out until about January of 2024. We're going to hit, and I think, an important date here this year, and I'll ask you to weigh on that, Mike. But just so the audience is listening knows when we're actually having this conversation. Yeah. But care coordination, never heard of this before. I don't know how, but can you explain that? And then talk to me a little bit more about what you guys are doing there. PlanSight is a complete game changer in the world of insurance brokering. As a broker, you know how time-consuming and error-prone the traditional RFP process can be. Well, what if I told you there's a better way? PlanSight is the only end-to-end RFP solution on the market made specifically for benefits agencies. It's like having a superpower that gets you an average of 8 to 10 hours back per employer renewal per year. And the best part? PlanSight supports all carriers, all funding types, and all group sizes for over 20 different benefits. If you're ready to make your RFP process faster, more efficient, and more profitable, it's time to call PlanSight. Visit plansight.com now to book a free demo and discover the future of insurance renewals.
Well, this is another, to use your reference about the road to hell being paved with good intentions. The law, and again, I'm not an attorney, so I'm just pretending.
You can play one on TV, though.
I'll
right?
play one on TV. But they set up a framework, again, with great intentions. They said, if you are receiving care for certain conditions, if your provider and the PPO network that your plan is accessing or using have a contract dispute and go out of network, you get 90 days to essentially continue to receive care at the in-network benefit level.
Okay.
Now, that's not an automatic right. There's things that you have to do as a consumer to gain access to that. Mike much more eloquently can talk about that. than I can. But some of the challenges that have come up with that is, so if you just think about a third-party administrator who's using a different PPO network that they don't own, you do not have access necessarily to the contract information for that care that that member is receiving after the contract terminates.
Okay.
So as a third-party administrator, one of the things we've had to grapple with is, okay, my wife has, is pregnant and has twins, and her OBGYN goes out of network 2 weeks before the delivery.
Right.
She can still have that care provided at the in-network benefit level, assuming she goes through the process of requesting and it being determined that it's appropriate. But the plan or the third-party administrator doesn't actually know what the contracted rate is, which has raised a whole bunch of challenges for figuring out, okay, at what rate do you pay these services? You have to pay it at the in-network benefit level, but how much am I supposed to reimburse for that specific service?
Well, how frequently is this happening? Because I mean, my naivety was when you brought it up, I said, well, I hadn't heard of this. So like, does it happen that often? So I guess it actually occurs more often than I thought, or has it accelerated in the last couple of years where this situation of provider changing contracts happening more frequently?
Yeah, I mean, we just saw this happen with a large health system in Phoenix. Phoenix Children's went out of network with a PPO network, national PPO network.
So the whole system. We're not talking about a single provider or physician. The whole system went. Okay.
Yep, the whole system went out of network, and that was one of the larger ones that's happened in recent times. But I mentioned it earlier. One of the challenges that just healthcare systems in general are facing right now, which most of us are, which is inflation. It's wage inflation. It's cost inflation to provide services, and there's increase in these contract disputes that we're seeing in comparison to 2022 and 2021. I actually just saw a news article that said the rate of intent to terminates that was out for major health plans and large health systems had tripled from last year.
Okay.
And as more of those happen, this
what's driving that, do you think?
I think it's basic economics. The health system wants a higher rate of reimbursement, and the health plans are trying to control costs.
Okay.
And so it's just they can't agree on how much is an appropriate rate increase.
I see. Okay. Well, anything you want to add to the care coordination conversation? And if we want to go back to no surprises, we can. I'm trying to obviously check a number of boxes, but keep it fairly concise because there's a lot of ground to cover. But any opinion on that?
Yeah, well, thank you for using the word opinion. I should say, obviously, I'm a licensed attorney here, but everything I'm sharing with you guys, this is my disclaimer, right?
Yeah.
So this is all informational and educational,
the disclaimer that I put in the post
Yeah.
in the description, I'll be happy to put that out there for you.
Of course, yeah. And obviously, if anyone listening has specific questions, obviously find a lawyer in your state that can help you guide you through this, because it is really complex. Yeah. But generally speaking, this goes back to that, patient protection and transparency, right? So you have these situations. This is just another, tweak on that same conversation with the medical bills. Now you have providers leaving the network, right? This is something that's happening outside of the control of the patient. And they have a series of 5 categories of patients who are in that same situation. You are in the middle of something that being asked to choose between changing your provider or accepting that they're now out of network and accepting the cost that comes with that isn't fair. So what they do is they provide this benefit to give you a little bit more time and buy you time to make that decision. So if you fit within the scope of the regulation, just as Josh said, it'll allow you to get a period of time up to 90 days where you can continue to see that provider at the in-network rate to buy you that time to make a good choice. Right. So it's not an indefinite extension, and now you can now see this doctor forever. It's to buy you time to accomplish really a couple of things: to make good choices with the right information in a situation that isn't stress-inducing.
Well, you're not under duress.
You're not under duress, right?
Yeah.
You have now the time to think about it, and you can make a good choice. Some people may choose to stay with that provider. They love them, and they're willing to pay the costs associated with it. Others may not make that choice, but ultimately puts that choice back in the hands of the consumer.
Yeah. Well, I like that. And I think what this is getting at, if I'm kind of reading in the spirit of the law, if you will, I think I've heard that term said, is like we're trying to protect the individual, right? And I love that, right? But we're also sort of poking holes in kind of the network itself, because what you're talking about is balance billing situations, out of network situations, some provider moving out of network during a period of care. And so at the end of the day, the person ends up getting stuck with it. I think that was one of the common early arguments against reference-based pricing, is that the member might end up getting a huge balance bill and now they're panicking. All of this stuff is good, right? The unintended consequences, I think we'll see shake out over time. One of the things I want to ask you about of sort of unintended consequences, these huge machine readable files, trying to parse and make sense and then turn it into a shopping tool. So talk to me like the state of affairs today of these really complex files, and then how do we turn them into something that a human being can actually make sense of and make choice out of? Either one of you guys.
Well, why don't I do the boring stuff?
Yeah.
I'll do the boring stuff. What are these files?
Yeah,
right?
what are they? Yeah.
So there's a series of 3 files that have to be produced on a monthly basis. There's an in-network file that has all of the in-network contract rates for your network, for the plan's network. There's an out-of-network file that has, I think it's a 90-day look-back period of all of the out-of-network charges and how they were resolved. And then there's a pharmacy file that has all the pharmacy data. Okay. And then within there, it is just massive amounts of information, so much so that most people and most plans and most systems, if you try and go find those files because they have to be publicly posted, will have a disclaimer that says, clicker beware. There's so much data in here, you might crash your computer, right? You just don't have the bandwidth in a personal computer to absorb and download all this information.
Crazy.
So that's the real problem, right? So you have this trove of data that you can't really access without specialized equipment. And now what do you do with it? And I think Josh can speak to kind of how we're using this information to really provide more information to our clients.
So before we do that, the format of the raw file, is it so complex because of the volume of data, or do you think it's in a format that's intentionally difficult to parse just to make it more complex to figure out the pricing? And are the hospitals perhaps reluctantly reacting to the enforcement side and going, well, here you go, and just have this really broken, fragmented data? What are your suspicions?
Yeah, so that's really interesting to talk about the hospitals too. So I think there's 2 things, right? There's just the volume of data that makes them impossible to use practically, right? But if you take that out and actually put it in a format or a size that an average person could access the data, what you're going to find is it's gibberish.
Okay.
There's not going to be a whole lot of value. It's not going to be a nice little Excel spreadsheet that says on Monday, Joe went to go see Dr. Steve and here's how much he paid, right? I'm not a tech savvy person, but it's going to look more like computer code, right?
Okay. Yep.
It's just not going to be very valuable.
I just am picturing the Matrix just streaming.
It's probably a pretty good way to look at it. It's not valuable to the average consumer.
Yeah.
Some of that is by design, just the way that the files are asked to be created, and some of it might be a little bit of that, I'm going to comply, but maybe not in the right way.
Yeah.
And focusing on the hospitals versus the plans is a really interesting dynamic because both are subject to these rules. The hospital's rules have existed since 2021, maybe January-ish, don't quote me on that, but a couple of years, where the requirement for plans to do it is only about a year old.
Okay. Yeah.
But there was a study that came out in the first quarter of this year that showed a differing compliance rate. So on your hospital systems, they, as of the first quarter of 2023, about 85% of them were complying, but that was up 20% over a year ago.
Okay.
And I think what you saw change is that the department started fining large hospital systems for noncompliance.
Yeah.
And once they started really kind of putting some teeth behind it, you saw that compliance rate go up.
Okay.
On the other hand, though, plans who have been required to do this for a much shorter period of time, you're going to see about 95% of them complying with the creation of these machine readable files. I could speculate, I don't really know, but I think it has to do with incentive structures, right? Okay. The plans are all about transparency and providing that information and helping their consumers control costs. As Josh said earlier on, it's one of our core tenets is cost containment and cost predictability. So a machine readable file fits right in with that overall scope. A hospital system, on the other hand, maybe doesn't have the same motivations.
Okay. Well, then how do you take what we're getting in raw form and turn it into what I think we can go into next is kind of that shopper experience, like consumer experience?
I just want to say, and this is my opinion, I was thrilled when this law passed because it finally gave, especially a third-party administrator and employers, access to contracted rates.
Yeah.
The large insurance companies, the large PPO networks had always stood behind, it's proprietary. We can't disclose, what our proprietary rates are with any given provider or hospital. And so the intent, again, of these machine-readable files was really, from my lens and from a product and strategy standpoint, a massive game changer for consumers, consumerism, and also for an organization like HealthEZ, who has a care navigation and advocacy component. So what we've done with the machine readable files, so 100% of our employers are compliant. We post the machine readable files specific to each employer on their custom benefit website.
Okay.
We have hundreds of employers. Each of them have their own custom benefit website that has their own plan, specific information. One of the things that we're focused on is making access to information easy. So we don't view a SPD as something that needs to be hidden behind a firewall. It should be something that you can just go type in a website URL and have access to it. And so we post the machine readable files on each employer's custom website. What we've done with that data, and we're processing and receiving these files on a monthly basis, is it is feeding our tool called Easy Choice.
Okay.
So there's the consumer facing portion of that. So Josh Schreiner, as a health plan participant of HealthEZ, can go shop for in-network, out-of-network services right through My HealthEZ or on our mobile app. And it's using the pricing that is from, in my case, America's PPO, our proprietary network. If you were in Texas, it could be Aetna's network, it could be Cigna's network. What's extra unique about HealthEZ is our advocacy organization. Actually, we use that same tool internally to help to navigate care.
Okay.
And I shouldn't say navigate care. The attorney's gonna. What I mean is help.
He's giving you the stink eye over here. Yeah.
What
I
I
have no
mean,
comment.
what I mean is help them to understand what the cost of care is at different sites.
Okay. Okay.
Ultimately, it's the consumer's choice on where they want to go and seek care. But our care navigation team is able to actually go type in a zip code, where a consumer is, look at the estimated price for that service, and can help them to make an informed decision.
Yeah, there's a couple things I like about this, and I want to expound upon the shopping experience, right? It's just, at the end of the day, the HSA or high deductible health plans were designed to make people better consumers. But the consumers were really armed with any information, right? The thought process is, if I put some ownership back on them from a cost perspective, they'll make better choices. But they couldn't make informed choices really because there was no information at their disposal to make an informed choice. So now what we're introducing is, how do I actually shop for a procedure or an x-ray or some type of imaging? I know where I'm going to go. I have a rough estimate of what it's going to cost me. In a very transparent way, in an educated way, I can make a decision as a consumer. So how close are we to getting towards that sort of idealistic type of consumer experience that I think we're all accustomed to in many other channels of our life?
I think it's going to take a long time.
Okay.
I think the law, again, great intentions. I use my wife as a focus group of one very often, and I ask her, when you're thinking about where you're going to take any of our kids to the pediatrician, or what OBGYN or whatever primary care doctor you're going to see, would you use this tool and make a decision based on price? And her reaction to me is absolutely not.
Okay.
I'm not going to go look up the price of a service in order to determine where I'm going to get my care. With that being said, I think what we are seeing is more incentive structures that are trying to help people to get over that hump. I was at a conference earlier this year, and the industry average utilization so far for these shopping tools was 11%.
Okay.
89% of consumers are not actively using a tool like this to go and shop. And HSAs 8 to 10 years ago, the thought was, if we do a higher deductible, we get consumers to have more skin in the game, they're going to make better decisions. Kaiser actually did a study that said as soon as a consumer hits their out-of-pocket, they will actually choose the highest cost care because they're no longer on the hook. So you actually have perverse incentives. So I think the tool is a great start to try to get information out for individuals to understand cost. But I think we have a long ways to go with consumers. And I think part of it too is just the complexity.
Yeah.
There's 15,000 CPT codes. A consumer doesn't, when they go in for an office visit, they don't know. Like, they're going in for a preventative visit. They don't understand what the provider is actually going to be billing. And so I think there is some level of, it's just overwhelming that causes individuals to not even take that first step to go look up the cost of something.
Well, I could see the application that seems the most obvious is some sort of outpatient procedure with sort of a middle of the road price tag. It's not emergent. It's going to be scheduled. It's something that I think is relatively routine. Let's use an example of a knee replacement, right? So not routine to the individual, but routine for these providers to be able to do on a day in and day out basis. And so like it's a bundle of like surgical procedures. There's other things that it encompasses, but I would look at something like that as an obvious thing to shop.
Yep.
To your wife's kind of perspective, shopping for a primary care physician or a pediatrician, I pick one I like or that's close and I go, right? Because the relative cost of that that encounter is not that big. The bigger the encounter gets in terms of cost, the more likely I think I would be personally to shopping. But the other thing that you and I are talking about over coffee, Mike, is that we're talking about cost, what Josh mentioned, but there's a quality component as well. And what we've seen a lot is that perhaps quality and cost are inversely related. But most people assume that if I go get a procedure that's the most expensive, it must be the best. So how do you look at quality, or how do we evaluate quality in that shopping experience?
Yeah, I think that's a really important component to it, right? I think it's very natural for someone to say, if I'm going to evaluate 3 different providers for a knee procedure, using your example, and one's going to charge me $7,000, one's going to charge me $10,000, and one's going to charge me $15,000. Your natural first instinct is to think as that cost goes up, you're getting a higher quality of care. And we would apply that in any, aspect of our life. About clothing. A $15 pair of jeans versus a $100 pair of jeans, we're going to assume that more expensive one is better. That is why it costs more.
Sure.
The reality is that's not always true. There are a number of components that weigh in on the ultimate cost with any individual provider's care. So adding on that quality component, I think, is a really essential piece to providing that full picture.
Yeah.
To both kind of arm the consumer with the information they need to make good choices, and then help the plans also go back to that controlling costs to make sure people are being directed to the right person for that situation.
And what is y'all's perspective on kind of the incentivizing through plan design, the use of shopping tools? Because I think that's one way you could get higher utilization, is if the member has some skin in the game or incentives to do so. So how would you, in your mind, design a plan that allows for that?
Yeah, we actually have a number of employers that have structured benefits using just basic benefit design as a way to try to tackle the situation of your example of an outpatient knee surgery. Our data tells us that if you have an outpatient knee surgery at a hospital, it's going to be twice as expensive as if you have it at an ambulatory surgery center. Not everybody can do that. There's medical criteria that allows somebody to have that procedure in an ASC versus a hospital. But doing simple things like changing the coinsurance to 0 for an ASC versus 20% for a hospital can help a consumer to make the right choice. I think the other thing we do a lot of, and it isn't so much as providing incentives, but we leverage the pre-notification and the pre-certification process to identify those non-urgent services that our advocacy team can help the member to determine, what is going to be the cost of that total knee. We have some great contracts in the Twin Cities where, if you go to the independent orthopedic practice, you're going to get the pre-op, post-op, 90 days of PT, the surgery, all the ancillary care for $24,500.
Okay.
The plan wants you to go there.
Of course, yeah.
Because if you go to the hospital across the street, it's probably $50,000, and that's just for the knee.
Yep.
That doesn't cover any of those other things that I mentioned.
Well, that's where I think you do in line, to correlate the members' consumerism with the plan's outcomes, is where if the incentives are set up properly to drive them towards those lower costs, but still high quality, if not higher quality outcomes, then you have them have skin in the game. They're actually aware of their role and responsibility within the broader ecosystem of that plan. If I want lower cost benefits as an employee, well, what am I doing about it, right? And that's where I think self-funding, and then the further you get along the spectrum of self-funding, the more you realize that individual has a big role to play and should be aware that they're in a self-funded plan.
Most consumers have no idea how much medical care costs.
Exactly. Yeah,
like if you somebody who's getting a Remicade infusion probably has no idea that the health plan is paying between $3,000 and, in a terrible situation, $12,000 per infusion. And we find that when consumers are actually armed with that information, you can actually change behavior. To your point on in a self-funded plan, at the end of the day, Josh Schreiner as an employee of a self-funded medical plan, if I'm seeking higher cost care and I can get the same thing, I'm going to end up paying for it through higher premiums, through higher deductibles, and it all just comes back full circle. And I think when consumers understand that, and then they realize that they can get, the same level of care at half the price, they feel good about making that decision.
Yeah, that's what, excuse me, there's a diffusion of responsibility that one of my colleagues talks about. My insurance card is basically my Amex Black, where there's no limit, and I just swipe it, and it's going to pay for everything. When you have that mentality as a consumer, that's how we lead toward these egregious, charges on the plan, and then everybody ends up paying more as a result of that. So you want that true consumerism, give them insight, let them know what role they have to play, and then empower them through shopping tools and through plan design to make those really, really strong decisions.
We try to encourage our consumers and our members through open enrollment, through marketing, through messaging. Call us as soon as you think you may have a procedure or need a service. And part of the reason for that is if somebody's been told they need a knee surgery and they've been referred to a specialist, it's a lot harder to intervene and get them to change a site of care than if they have just gotten out of the urgent care at the Twin Cities Orthopedic in Minneapolis and found out that they tore their ACL and they're going to need a surgery. You have a lot better chance of helping to influence the decision-making process if they haven't been referred anywhere.
Yeah, absolutely. Why don't we do this, Mike? I want to kind of pull you in and ask about gag clause attestations, because I think that's something I'm hearing a lot discussed publicly. Kind of the sentiment is not a lot of people are really compliant. But what you have kind of opinion on that? Maybe we even state what it is real quick in case not everybody knows what it is, and let's talk about that subject for a couple of minutes.
Yeah, so the gag clause attestation requirement is just kind of the latest rollout. Like we talked about before, there's No Surprises Act is actually a couple of years old, but it's been rolled out in phases over the course of several years now. And the new one here coming up in the next couple of weeks at the end of the year is this gag clause attestation requirement. So what are you talking about? Because that just sounds like a mouthful, right?
It does, yeah. I have a hard time saying it every time I say
most people do, right? So what do we really mean? And it goes back to what we were talking about before when it came to the machine readable files and the confidentiality clauses and understanding what rates would apply to what services. And what this is a new law that says these types of, they call them gag clauses, but they're really confidentiality agreements that would prohibit a plan, its participants, or any of their service providers, their business associates, from accessing certain types of cost or quality of care data. And it says these types of contractual provisions are now prohibited. So that's been the law for a couple of years, but it was a passively enforced law. It just kind of got written on the books.
Yeah.
I think most people took the approach to say, good to know. We're not going to really do anything about it because if we come across these, the law says they're not valid anyway, so don't have to do anything.
Right.
This past year, now it's become more of an active law where each year a plan has to go out to a portal on CMS's website and affirmatively attest that their contracts don't have these clauses. And that really flips the switch. Quite a bit because there's a lot of contracts coming into play and there's a lot of choice. There's a lot of ways you can set up a plan, which turns into a lot of different places you need to look. It's not simply picking up one rock, looking under that one and calling it good. So it's a real challenge for health plans to comply with. So HealthEZ is trying to help them as best we can. So we've taken the position that we've reviewed all of our contracts and we've looked at them all and we have confirmed that we comply with this. And we do this a number of ways. And the front end when we're contracting, it's one of the things we always look for. And if you have these situations, it becomes a really important negotiating tool. There's kind of the belt and suspenders approach to it, where we actually put in affirmative clauses within our contracts that say, if we missed something and that thing we missed would otherwise violate this law, this next clause invalidates that and just says affirmatively, nothing in this agreement is intended to violate this law. If something else in here does, that's going to be overridden by this other clause.
Okay.
And then we provide information to our plans, because that's the big challenge with all of these, is as a TPA, none of these requirements fall on us. We're just a service provider. They all fall on our clients. The reality is, though, the TPA or the PBM or anyone other than the ultimate employer who's sponsoring that health plan is probably not in the best position to actually do all this compliance work. So we do a lot of education, and we're in the middle of doing that for our clients right now. We're educating them on both what is this requirement, how can we help you, where else should you look? If you're bringing in your own PBM, if you're bringing in a stop-loss carrier, if you're working with a consultant, go look there too and ask them these questions. And then once you're comfortable, here's a user guide on exactly how to go out and do this.
Yeah, that's just it, right? I think it's so new and it's so fresh, and everybody's going, what am I supposed to do? I want to be compliant. I'm saying that I'm moving directly towards compliance, but we don't even know exactly what compliance looks like. Isn't one of the components of this, am I paying a fair market rate for claims or for procedures? Is that a component of it as well?
Not of the gag clause specifically,
okay.
but you can see how these all kind of fit together,
Okay.
right?
Yeah.
We talked about at the beginning, there's 10 or 11 components of this, and they're all interrelated. I think we've kind of hit 7 or 8 of them already by just having this conversation, because talking about talking about the price comparison tool necessarily talks about the machine readable files.
Right.
And being able to create the machine readable files means you can't have the data be confidential. So now you're back to the gag clause. So you have all of these things kind of building on top of one another. So when it comes to sharing that data and working with it and making it available, that's what the gag clause is really trying to do. So you have the machine readable file, which lays out the format that this information should be provided. You have this gag clause prohibition that prohibits someone from taking a position and contractually trying to avoid their obligation. And then you have these other things that try and build upon that information to ultimately get to your real goal, which is providing information to the consumer so they can make the best choices.
Well, and who are you seeing these employers mostly lean on then? So if it's not necessarily the TPA has got kind of primary responsibility there, is that falling to the laps of the consultant? Are they taking the onus here, you think, most of the time? Or like who are you seeing?
I mean, the consultants are the ones, at least from I deal with brokers, consultants, employers on a daily basis, and the consultants are asking the question. They're asking the question of the TPA,
okay,
or at least in our case, they're asking us.
Well, we're not like this in that Spider-Man meme where we're all Spider-Man, we're all pointing at each other, like who's responsible, like who's on first, kind of thing. But
I think that is probably true. I think there is a component of that because of a couple of things, right? There's how the law is written, which clearly puts the onus on the plan. Then there's reality, which says the plan's probably in this whole ecosystem the one least equipped to actually comply.
Yeah.
So then it becomes who's going to take the lead. And the third problem is not any one person has all of the information. There's not a clear answer that says, well, the TPA has everything, so the TPA should do it. TPA has a lot of it. We have access to a lot of it, but we certainly don't have access to all of it. So our approach had been kind of that ground, which is we are going to help where we can, which is educate, inform and advise where we have visibility into your plan, advise you on and tell you where else you should look, where we don't have visibility into that plan, kind of give you some things to think about. And then if you've become comfortable with this, here's exactly how you go ahead and do that.
Okay. Do we think we're going to see any big examples made of employers, or to really just establish that we're serious about this law? I mean, do you think that's coming?
I think we're starting to see, and I don't think it's widespread, but we're starting to see, there's individuals on LinkedIn that are requesting, gag clause attestations from large carriers.
Okay.
And finding in a lot of cases that those gag clause attestations are not sufficient in their view. I think Mike talked about it earlier. We saw the hospital systems have this, requirement to post pricing 2.5, almost 3 years ago. And until there was enforcement, there was very, very low compliance. Mm-hmm. And so I do think at some point we will see. One thing that I find interesting, and I've spent now almost a decade focused solely on self-funding, is all of these laws, when they were written, were from what I can tell, were focused on carriers. They weren't thinking about self-funding, and they weren't thinking, even more so, they weren't thinking about third-party administrators. And so there's been a lot that, I don't want to speak for Mike, but that I've learned in the last 18 to 24 months about how little was understood about who's paying claims and who has access to what data. And it's, the gag clause attestation is just another example of, the rules were not, the law wasn't as clear, and there's, this super highway that you got to try to decipher who's really responsible.
Yeah. Well, that's what I was kind of digging at, and I know we went off a little bit in the weeds there, but I think it's relevant to discuss this deeply, and it's not a simple subject. It's not a simple answer either. And just making people aware that some of the onus is going to fall on their laps. They need to be paying attention to this type of conversation. But why don't we do this? Let's kind of pick back up and kind of move big picture and close out the podcast here soon. But let's talk about kind of the future of healthcare and both of your vantage points, right? So we got the product side and then we've got the legal side. Kind of like, where is this old wooden ship moving? If you guys had a crystal ball, where do you think we're going in the next few years? And what should we be thinking about as consumers?
I think this law has been a catalyst to hopefully more consumerism. I'm slightly skeptical just from history's past and other efforts that we've made as a country to try to empower consumers. And I think just when I think about it for my own family or for myself, healthcare is such a personal thing that trying to get people to think rationally about it is going to be a continual challenge. And we were talking earlier, there's transparency on pricing for just everyday services, outpatient services, but the level of, cell and gene therapies and other high cost services that are coming down the road for employers, whether they're partially self-funded, level funded, or fully insured to the carriers, I think we're going to see a very dramatic change in the cost of healthcare, which is a scary thing to think about when, other than the last 2 years, healthcare costs have outpaced inflation.
Yes. Oh, yeah.
And it's only going to get worse. We had an organization in our office a few months ago talking about all the new cell and gene therapies that are about to hit the market, and these are things that are $3-4 million.
Oh yeah.
And how is a 250 life employer going to grapple with that? How is a stop loss reinsurance partner going to grapple with that? And I think, I don't know if this was directly answering your question, but I think that's the thing that that's what keeps me up at night.
Well, I'd certainly say, and I would agree with you there, gene therapy is most top of mind right now for us internally at Pareto Health, but just industry-wide, I hear people talking about gene therapy. And some of it is just really the price tags themselves, right? We don't know how many of these actually are going to apply, when they're going to apply, what the true efficacy of a lot of these drugs are. And when you start getting into the nuances of who should take it and some of the drawbacks of doing it versus the staying on their maintenance medication, they start to look less and less enticing from a consumer perspective. And so we'll see how it plays out. But the entities that I know that are looking into this, that are projecting it forward, are looking at humongous increases in the utilization of these gene therapies. And so it's absolutely top of mind. I think we're going to have to figure this out one way or another. We don't have any choice. But what kind of, from a legal framework, though, I'd kind of shift gears a little bit, like big picture healthcare from your perspective, because you have a unique lens here. Like, are there regulations that you're focused on coming down the pike, or there's things that you're preparing groups for 2024 and beyond?
ClaimDoc is a medical claim auditing and member advocacy company. We provide fiduciary services to employer-sponsored benefit plans, and allowing them to create an environment where we ensure that the benefit plans are being charged on a fair and reasonable basis.
My business is basically people, and it become a real simple transition. We thought it was going to be far more complex. I've saved, we'll say, hundreds of thousands of dollars. I could not say enough about ClaimDoc.
Yeah, I think it's going to be the same two things we've been talking about, right? It's going to be transparency and compliance, right? I think the clear weight of the momentum is pushing towards more information, more transparency, more visibility into everything that goes into a healthcare service, right? To and kind of empower the individual to have the information they need, and then let the free market work. That's how this whole system is designed, to allow people to make good informed choices that work best for them. There's no steering someone to a specific situation because that's where we want them to go. It's empowering people to have the information they need to make the best choice for them in that situation. So I think you're going to continue to see efforts to pull back that curtain and both create the information availability, machine readable files being a great example of that, and then pushing, whether it be plans or service providers, to turn that information, that raw data, into something usable. And I think that's really a big focus here at HealthEZ is taking that next step. Obviously there's the compliance component, there's the check the box component, but actually using it and empowering individuals to use that information to make good choices is in everybody's best interest. So really turning that into something that's useful is really a big focus on our end. And I think you're going to continue to see that. And then there's going to be the stick component, obviously. So there's the carrot, right? If you do these things, you may be able to control costs. You're going to be able to do some better steerage. Then there's the stick on the enforcement end. And I think you'll probably see some of that picking up. You're starting to see it a little bit in certain areas. There's usually a lag time there because none of this is easy. So generally the attitudes of the regulators on the front end is education and assistance. We want to help you comply with this law. The law exists as a tool to provide information. It's not just another reason to ding you with a fine. So for the first 6 months to a year, that's the focus. Ask your questions. How can we help you? Where are you falling short? Where do we have to clarify? But at some point, that shifts from you've now had that time to ask questions, and now we're going to go to the enforcement end and the enforcement side of it. Because if you're not complying, now we're going to start making you. So I think you're going to see those things kind of from the new regulation standpoint, more focus on transparency across all the service providers. And then on the enforcement standpoint, that transition from the education piece to the enforcement piece.
Yeah. Well, I think both of those are important, right? I mean, I'm a bigger fan of the incentives up front to change behavior before you start wielding the stick, but obviously both of those are going to be required. I think from an employer perspective, hopefully by attempting to comply and informing oneself, the end goal or the end result will be I'm bringing down the cost of healthcare spend. So if we have that outcome in mind, this is a mechanism to achieve that end. And I think the more you lean into it, the more likely you're going to realize that sooner than later. And so that should be enough incentive, broadly speaking, whether or not there's regulations requiring it or not, because the information is now available. I want to follow up real quick and just, I kind of thought of something when you're talking about individualized healthcare, and then after that, I'll just ask you guys sort of just open forum, whatever you want to say to close out the podcast. But what role do you think wearables and data and those type of things play in individualizing healthcare?
I think those, that's a fantastic question and something that's top of mind. So one of the things that we strongly encourage employers to do is health risk assessments, which isn't necessarily about wearing a wearable, but getting consumers to understand the state of their health is very important for reducing and preventing costs in the future. And when you leverage health risk assessments, that gets consumers thinking about, very basic things like what is my A1C, what is my cholesterol, what is my BMI. But if you can then get consumers focused on that and tie it into making healthier lifestyle changes, that you can then exchange data with, whether it's a coach or a nutritionist or whatever type of service that the employer or the plan is purchasing, you can have a big impact on costs. We saw with a 750 Life employer group, they did 3 things around diabetes. They turned on coaching, they made insulin cost-free, and they made supplies free. And the first year that they were with us that they didn't have any of those things purchased, they were spending almost $20,000 per diabetic in medical costs over the course of a year. Through August of last year for this school district, those costs are now down to $11,000.
Yeah, I believe it.
And so doing things like that, making the investment for your employees, can actually return results.
Absolutely. I like the multifaceted approach that included, the coaching aspect as well. I had a post about this last week about, the role that diet could play in kind of remediation or remission of diabetes. I think it's possible, right? So you attack it from different angles, but as they're going through that process, continuing to be adherent to their maintenance medication, obviously, is crucial. But empower them, give them tools to change their behavior and change their habits over time too. Obviously, will draw down costs. Well, this has been a long podcast, but a good one. That's why I'm keeping it going. And obviously, thank you for both of you guys for coming down. But why don't we do this? Closing thoughts from both of you guys. Open forum, just kind of summarize today's episode, and then I'll just weigh in on the back end. But Mike, why don't you go first?
Yeah, no, I appreciate you inviting us down and that we got a chance to talk about things that we're fairly passionate about. So I appreciate the opportunity. And I think the one thing to keep your mind on is where the ship's moving. And it's in this compliance kind of focus and making this no longer a check the box thing, but something your consumers are ultimately very concerned about. We've spent today talking about one very specific component, this No Surprises Act. And it's even broader than healthcare, but it expands out to everything. There are constant articles, stories, concerns, new laws just on general privacy in the world generally, and your information. And people are concerned about this. And as people are concerned about it, the regulators are going to be concerned about it. And they're going to start asking questions about it. And your consumers are going to ask about it. So instead of waiting for a regulator to come in and say, you have to do this, really start thinking about what are people concerned about and how can you make that an asset? And that's something we're thinking about all of the time, is what are the things people are concerned about when we're this involved in their healthcare, and how can we ease that concern to not only stay compliant, but allow them to get the information they need to make good choices and to continue to achieve the goals they're ultimately looking for.
Yeah, absolutely. One thing I'll say that I'm impressed, and this is our first time to really sit down, is that you guys are thinking this really holistically. It's because when you think of the bucket of a TPA, most people have in their mind, if they have experience, this is what a TPA does. Obviously, the suite of things that you're providing under the umbrella that is HealthEZ is much broader than simply just TPA services. And so I appreciate your ability to wrangle all these things together and make them cohesive for an employer. I think that will be very, very effective for you guys going forward. But why don't you get closing thoughts from you, Josh?
Yeah, want to thank you. This has been fun. It's always nice to talk to other individuals that are passionate in this space. I know Mike and I have lots of discussions. For those of you that are listening, you can go to healthez.com/NSA. We actually have a whole landing page of information that gets into even more details.
Well, now is that National Security Agency?
Yeah, no surprises act.
Okay, that's probably relevant. Yeah.
But that'll give you kind of a high level on all the things that we include in our NSA transparency and coverage compliance solution that all of our employers have. And I think to Mike's point and to what we've talked about today, continuing to try to engage consumers to make good financial decisions is, it's the responsibility of all of us to make it as easy as possible. If we don't make it easy and consumers don't have access at their fingertips, they can't make good decisions. Yeah. And so I think for me personally and for HealthEZ, that's our goal, is to make it as simple for our customers and our members to gain access to the information they need to make good choices.
Awesome. Well, gentlemen, this has been a lot of fun. And my only regret is that we are going to have to close it out because I think there's a number of subjects that we covered earlier that I'd love to dig into further, but maybe we'll do a part 2 at some point. But this has been great. Thank you for opening my eyes about a number of things. If you'll remind me, I'll make sure to put that website link in the post as well so people can check that out. I think it's a great resource. And hopefully we'll look back in 2024 retrospectively at this conversation, since we are forward looking a lot in today, and hopefully we got a number of these things right, and we shall see. But thank you again for giving your opinion. Thanks for traveling down, and I look forward to doing this again soon.
Thanks for having us.
Thank you for having us.